you'll find that everything we talk about, chronic diseases, it doesn't matter what the chronic disease is, there's going to be some element of nutritional guidance, that is dietary input, that's going to be necessary to talk about. So we're going to talk today about the cultural and the medical aspects of why it is we spend so much time talking about how and what you eat.
I am Dwight Reynolds, board certified in emergency medicine, and from the Cleveland Clinic. And I've been a doc since, well, for a lot of you were born 1978. So don't laugh. Just be blessed to get there if you get there. Amen. Dr. Gavin, who is my partner in crime, he has a new title that's been assigned to him. So you'll see it from the first half probably. This is Dr. James R. Gavin, the third MD, PhD. And I always tell people, know who your presenters are, because to me, it's very important. We're so blessed and fortunate. I tell people every time that we do our webinars, have Dr. Gavin on board. So because of his, how can I say it? Because of his input, because of his leadership in guiding this young doc, okay, I have made him the curriculum director. But he accepted, which is good. So he has a lot of things coming to him, but again, he really makes this program work. So he's responsible for most of the content. Yeah, I'll be still responsible for a lot of content, but Dr. Gavin is going to be the guy. I think I have maybe 1 minute left to go. Then there's Dr. Demetrius Morrison. That she has so many initials behind her name. I don't think I put them all in here, but the big one for us is she has a doctorate in, I think it's clinical nutrition, master's in public health. She's also has masters in nutrition as well as dietetics. She is one of few African Americans, male or female, in the country that has that distinction. So again, God always blesses us with people that he wants us to be surrounded by. Then, of course, I read our mission statement. To me, it's important. CHP's mission and vision statement. Our mission: to serve as patient advocates and educators, restore trust in healthcare providers, improve patient outcomes, and extend the lives of every patient in our care. Our vision: a world where everyone receives first-class health services they can believe in and trust. And that's really critical now because we're going through some changes, as you guys know, throughout our country. Everything we do aligns with this mission in pursuit of our vision for our communities. So I'll throw it over now to Dr. Gavin. I think I took a little bit less than 4 minutes at least. So Dr. Gavin, you should have the mic now.
Thank you very much. And thank you for that prayer. Thank you, Dr. Reynolds, for that introduction. And we are thankful for your leadership and for all that you do to steer this mighty ship called CHP for the good and for the health of our people. I'm pleased to be joined today with my co-presenter, or with the principal presenter, Dr. Demetrius Morrison, who will will actually keynote this topic today: what to eat to stay out of the hospital. I'm going to set this up by giving you some introductory comments that basically will try to point out what it is that causes us to introduce topics like this for you. Because you'll find that everything we talk about, chronic diseases, it doesn't matter what the chronic disease is, there's going to be some element of nutritional guidance, that is dietary input, that's going to be necessary to talk about. So we're going to talk today about the cultural and the medical aspects of why it is we spend so much time talking about how and what you eat. Every medicine that we have that is used for managing a chronic disease is based first and foremost on the principle that that medicine is going to be used in conjunction with the proper kinds of dietary support. Okay, so why do we need to watch what we eat? Well, there are a number of important reasons, and this is what we're going to try to get into. First and foremost, for the sake of chronic diseases and for the sake of our overall health, we're trying to avoid to the extent that we can, becoming overweight or obese. Understand that the foundation of any medical treatment plan, means that we have to have the appropriate use of diet and exercise. Those are the foundations of therapy for virtually any chronic disease that we ever talk about. All of the drugs that are approved, for example, for the treatment of diabetes are expected to be used in conjunction with appropriate diet and exercise. In other words, there is no medicine that you can't out-eat. None. So when we think about the challenges that we have to trying to set up a dietary plan that is going to be compatible with healthy lifestyles, we have to think both medically and culturally, because all of us derive our eating patterns from how we grew up, how we were socialized. We know, for example, among African Americans, I grew up in Mobile, Alabama. My mother's people were all from Selma, Alabama. We embraced soul food. Now, it turns out that there's a lot of healthy options in traditional soul foods with good fiber content, good vitamin and mineral content, okra, collards, sweet potatoes. But there are also the other side, meats with high fat content, especially meats like different cuts of pork that are seasoned and have large fat content. And fat intake may, in fact, comprise up to 50% of the calories in some of these meals. So choices are important. And we have to find ways to improve our intake of fruits and vegetables, which right now may be very low. If we look at dietary challenges that are culturally based, then throughout this hemisphere, it's very different. Just keep pressing, Dr. Reynolds, because what we'll find is that in Mexico, in Central America, and in the islands, and in South America, there are different patterns of food. So that's why we have to culturally adapt how we make dietary recommendations, because there is this cultural and ethnic component to eating wherever we are. Next. The big target in most of what we are trying to do in these discussions about the appropriate structure of a diet plan is the avoidance of obesity and overweight, because this has been a legacy of our nation. Remember that one of the biggest epidemics that we have right now is this epidemic of overweight and obesity. This is a cultural challenge. This is a medical challenge. And there are consequences, and this is really the focus of all that we talk about in these chronic disease discussions. Being overweight, for example, can lead to high blood pressure and a number of other complications like stroke, blood vessel damage, atherosclerosis, heart attacks, kidney failure, and a variety of other complications. Next. If we look at obesity as sort of our central focus, organized around this discussion on diet and nutrition, obesity is only one of the reasons that we focus on healthier eating. Patients with type 2 diabetes, for example, and I consider type 2 diabetes a flagship chronic disease because it is so central to so many other diseases. People with type 2 diabetes are at risk for other kinds of diseases and complications because these conditions never travel alone. If you have somebody that has type 2 diabetes, there is a significantly increased likelihood that they're also going to have hypertension or high blood pressure. Yes, they're going to be overweight, obese. Large percentage of them are. And a large percentage are going to be suffering from high lipid levels in their blood. And not even shown here is that a large percentage will be affected by kidney disease. In fact, next, what you'll find is that if you attach numbers to this, in people with type 2 diabetes, over 80% will have high blood pressure. About 80% will be overweight or obese. And about 80% will have hyperlipidemia. And if even before the diagnosis is made, over 40% will have kidney disease. So the prevalence of at least two of these kinds of coexisting complications will occur in people with diabetes 90% of the time. They will have 2 or more of these associated conditions. So that's why we focus so sharply on identifying those things that are helpful in reducing these kinds of complications. And one of those is how we eat. Next. If you think about chronic kidney disease, now most of us never think about the fact that treating chronic kidney disease begins with, look at the bottom part of this treatment pyramid. What does it say? The basis of treatment for chronic kidney disease consists of what? Diet, exercise, not smoking, and weight control. That's the basis of treating chronic kidney disease. That's before you get to any drugs or before you get to any of the specialized treatments for kidney disease. And it works this way for every last one of the chronic complications associated with diabetes. Next, it's also true for heart failure. Most of us never really hear about the degree to which heart failure is a major complication in diabetes. What this slide shows you, going from the top to the bottom on the left, 2 years down to 15 years. The longer you have diabetes, if you look to the right, you see in blue, myocardial infarction, heart attacks. What are your risks for heart attacks? In orange or whatever that is, bronze, you see heart failure. Notice that as you have diabetes for longer and longer periods of time, your risk for heart failure is actually higher than your risk for heart attacks. Why is that important? It's important because heart failure is a very difficult complication to treat. It occurs early, it's very debilitating, and your prognosis, if you have heart failure, is like the prognosis of certain cancers. So heart failure is another one of those complications. And what is the foundation of treatment of heart failure? Just like all of these other conditions, you start with how you eat, what you eat, okay? Next. Next one. So all of these diseases, these cardiovascular diseases, really stem from a major single event, and that is blockages of the vessels. Okay, in the heart, if your vessels are blocked, that's coronary artery disease. In your brain, that's cerebral vascular disease. That's what gives you strokes. In your legs, it's peripheral vascular disease, the limb vessels. And in the kidneys, that's renal vascular disease. In all of these major organs, the problem that we have is that there is early and excessive blockage, and it leads to these conditions like heart failure, heart attacks, strokes, kidney failure. Now, you've heard of atherosclerosis, okay? Hardening of the arteries. These are processes that can be local or they can be widespread, and they happen slowly. What are the things that drives the development of atherosclerosis? It starts with what you do when you sit down at the table. Okay, next. One of the most powerful contributors to what happens to our blood vessels is cholesterol. If you look at this little diagram, the normal artery, the normal blood vessel that we have in our body is lined with cells that are just like they are smooth as glass. That's a normal cell because everything should be flowing smoothly and without interruption and without turbulence in your bloodstream. That's the way our bodies are supposed to be made. You cut you cut an artery open and look down like a pipe. You should see what you see on that top diagram. Should be very smooth. But then we get these things called plaques. Cholesterol is the major culprit here, and you start to see a narrowing of the lumen of that channel that everything is supposed to be flowing through. Now you got turbulence, and turbulence is not a good thing. Next. Cholesterol is the major culprit. It's a dietary element. Too much cholesterol in your blood causes that kind of buildup, and your heart has to work harder, pushing things through a clogged up system of pipes, arteries. That means if it's not possible to get blood smoothly to your brain, what do you get? A stroke. If it's not possible to get blood smoothly and uninterrupted to your heart, what do you get? A heart attack. If it's not possible to get blood smoothly and uninterrupted to your kidneys, what do you get? You get kidney injury and kidney failure. And so next, what you see then is that what should be normal, smooth, open vessels, now you see clogged up. And you see that thick red area that's causing those blood cells to build up behind it. That's a thrombus. That's a clot. And that's the culprit that we are trying to avoid in all of these different conditions of stroke, heart attacks, and kidney failure. Next. Now, go back one slide. Notice this note at the bottom. Notice that cholesterol is a nutritional element. Along with many of the chemicals that we have in our bloodstream, what your cholesterol level is one of the earliest markers of whether or not you're eating right. And that's why we focus on this topic of what it is that you need to be eating and how you need to be eating in order to keep out of this kind of trouble, which leads you to the hospital. Okay, so the whole issue next of eating right is our focus today. What is eating right? And that's why we are really privileged to have Dr. Demetrius Morrison, who is going to talk to us, going to guide us through a discussion on what it means to really be eating. Let's say eating right, but let's use another term, eating healthy. Okay. And so, Dr. Morrison, I now will turn it over to you. And rather than nodding, you'll have to tell Dr. Reynolds next, just like me.
Thank you so much. Can everyone hear me?
Yes, go ahead, doctor.
So our diabetic goals and objectives will be to reduce the burden of diabetes and improve quality of life for all people who have or who are at risk for diabetes. The objective is to increase the proportion of people with diabetes who get proper information and education to make an informed decision related to their health. Our second goal is to reduce the proportion of adults with diabetes who have an A1C of 9% or higher. Some racial and ethnic minorities are more likely to have diabetes, and many people with diabetes don't know they have it. So I can just tell you as a clinician, a lot of times we do get people who come in the ER with DKA, diabetic ketoacidosis, and they only know they have diabetes because they were quote unquote peeing a lot, or they were feeling like they were thirsty, but they didn't have no knowledge before they had that experience that they were walking around with elevated blood sugars. And we know that's not healthy because we know the blood sugar is supposed to go in the cells and not sit in the bloodstream. Next slide, please. So hypertension goals and objectives are to lower blood pressure and reduce the risk of heart disease, stroke, and other cardiovascular complications, aiming for target goal ranges of 120 over 80. I know that seems like a very, very impossible number to reach, but it can be done. Our objectives is to reduce morbidity and mortality and to decrease the burden of cardiovascular and renal disease by lowering blood pressure. We want to manage coexisting conditions that influence blood pressure, such as diabetes and kidney disease, which is a vital part of achieving overall health goals. I know a lot of us as clinicians understand hypertension as the silent killer, but you guys, if you're able to afford a decent blood pressure machine, you don't have to have high blood pressure to check your blood pressure. You don't have to have diabetes to check your blood sugar. But if you have it in your family, it's in your best interest to find out if you're at risk early on, way before you get symptoms of pressure in the back of your neck or anything like that. Know your numbers. The healthy range, like we said, the top number is the systolic. So we want that 120 or less. And the diastolic, which is the bottom number, is 80. What we consider elevated would be anything between 120 to 128, and the bottom number, again, less than 80. Stage 1 hypertension is between 130 to 139, the top number, and then the bottom number diastolic is between 80 to 89. And stage 2 hypertension is 140 or higher, the top number, and the bottom number 90 or higher. Hypertension crisis is over 180, the top number, and the diastolic or the bottom number is over 120. And sometimes we're walking around at hypertension crisis and we're not aware. We're not aware until we've had that crab boil, and we've had whatever food we wanted to eat, and our head feels like it's about to explode. We don't want that type of pressure sitting in our bodies, our vessels, our arteries at ER level. We want to get proactive. We want to make sure that we know these high blood pressure numbers. Take a picture of this grid, because it's important that you know your numbers, and don't let you going to the doctor be the first time you know your numbers. You should be able to go to your doctor and have some type of running log of your numbers. You should be able to say, I've been recording my numbers. I notice I run high around 7 8 p.m. I notice I run normal at a different time of the day. You should be able to communicate, your concerns of your blood pressure to your doctor. Blood pressure is something that we don't take lightly. We don't play around with. We are prone to having high blood pressure just because of life stressors, because we're overweight, because we don't eat well. So we already have some factors against us. But that doesn't mean that we can't get you back to healthy range. It just means that it's going to take a lot of intervention and a lot of consistent effort. It's not a one-time thing, and that's why we're grateful here to be before you, sharing about what you need to do for your health. Next slide, please. Like we said before, know your numbers. So we know that these are important numbers to know. According to the NIH, National Institutes of Health, when you do go to your doctor, most often they order a hemoglobin A1C or a fasting plasma glucose level, and you want to be an educated patient. I love educated patients. It makes our care for the patient easier. So ideally, normal hemoglobin A1C would be less than 5.7. Pre-diabetes is 5.7 to 6.4, and 6.5% or higher is diabetes classification. Again, if you know you have a strong incidence in your family, we don't want you to wait till it's too late for you to realize you could have controlled these numbers way before. And these numbers are reflective every 3 months. The glycosylation, or the layer of sugar over a cell. We do want to take these tests like every 3 months to see if there's any improvement. And there can be diet-controlled diabetes. You could easily control your blood sugars with diet alone, but again, you have to take your health serious. With the fasting plasma glucose, ideally the normal range is less than 100. Pre-diabetes is 100 to 125, and diabetes is over 126. We've already spoke about the normal ranges or ranges you need to know about your blood pressure. Again, screenshot this page. Know your normal ranges for diabetes as well. You don't have to get diabetes because your mom and your grandmom and your grandfather had it. You don't have to. You don't. You can stop that in your bloodline by your exercising, by your eating. Even if you take medication, it can work for in your favor. Next slide, please. So foods to eat to help with blood pressure. No, sorry, you're not gonna see the crab boil on here. I'm sorry. But you will see dark green leafy vegetables. That umbrella includes cabbage, collards, mustards, turnips, Brussels sprouts. That's dark green leafy. I do mention wild rice. I won't probably do the processed white rice, but I do mention yuca because some of these foods are high in potassium. Brown rice, couscous. I've taken a liking to that. Quinoa or quinoa, barley, or in some cultures it's called pitimi. Whole wheat pasta, cooked dried beans. These also could be your healthy complex carb sources. So you don't necessarily have to get the traditional bread as a carb source. We do encourage fresh fruit. We're here in Miami, the Tri-County area. You get some real tropical fruits, dragon fruit, lychees, your traditional mango. We want you to get the vitamin C in. We want you to get what you need, the lycopene, the unsalted nuts. We want you to get that. That's necessary. Unsalted salads, preferably anything with a romaine or darker color. We don't really do the iceberg. Yogurt, we don't suggest with the sugar, but natural food you can add to it. The oils, I know there was some conversation about vegetable oil because it said they were vegetable. That's very misleading and deceptive. Vegetable oil is not one of the healthier oils. However, extra virgin cold pressed olive oil is, and the metal can. So it's just like some requirements with olive oil. Don't get the one in the plastic bottle. Get the oil that's protected in the metal can, and make sure it says extra virgin cold press. Make sure it says that the olives are cold pressed. Avocado oil, flaxseed oil. Obviously, if you want to deep fry something, that'll be your peanut or coconut oil. But for your healthier oils, if you want to stir fry something, you want to put something in the oven, this is what we recommend. Sadly, canola oil is a genetically modified oil from rapeseed oil. We don't promote canola oil at all. And we want you to understand we don't have to necessarily cook with oil at all. You could definitely put everything in the oven and a stir fry, steam, bake, grill. You don't have to fry. I mean, that's not, we don't want to claim that identity. It's okay occasionally, but fried foods are not our friend. So we do ideally want daily at least 2 cups, or throw it in the blender and juice it. These are all good examples. These are not limited to what you see here, but you're gonna have to go to the grocery store and buy these items. You won't really have it in the restaurants because everyone's on a fixed budget when it comes to business. So if you desire to have, for example, a chicken wrap, and you didn't want to use a pita bread, you can use collard greens. I was introduced to that concept at Maryland University when we had our first orientation as doctoral students. They had collard green chicken Caesar wraps, and I never saw that before. So it's just trying to get in your nutrients in a different way. You could also put your collard greens with your cucumber in a juicer and just get your natural diuretic, your natural vitamin K, your natural vitamin C. Just get what you need to get for your body's sake, and move and keep it moving. And every now and again, if you want to be bad, that's fine. But if you continue to eat healthy more often than not, your body will treat you differently. You will see, you'll not get the chronic diseases. So regarding blood pressure causes and symptoms, you see here stress. Stress is something that's personal. Preparing for an exam could be stressful, or just trying to manage the kids in the morning. It depends on your level of stress, what can cause your pressure to go up. A high diet in sodium, and I could also say low in potassium, because they do work in tandem together. Also, lack of exercise, something that we do need to do. I know that it's very convenient. We drive everywhere. Our houses are air conditioned. Our workplaces are air conditioned. But put on that sweatsuit and just sweat out that salt. Just sweat it out. Genetics and other health factors from what you've seen. Genetics meaning that you saw your grandma have it, but if you copy her lifestyle practices, more often than not, you'll get the same outcomes. It's no, that's what I want to emphasize, the health factors, where if that's all you were exposed to, that's all you're going to mimic or copy. Some symptoms may be headache, fatigue, dizziness, increased heart strain. How it affects the body, it hardens the arteries. Also, it affects your kidneys. Also, it affects your brain. Also affects your heart. That pressure is not good. Inflammation occurs or increases. And I know I can just tell you my experience where, not mentioning any names, I had a consultation even yesterday, and that particular individual said, I just love McDonald's. That's all I eat every day. And I happened to ask how often, and that person responded, every day. I eat it breakfast, lunch, and dinner. And there was a whole study, even on, I think it was a documentary, where a young guy documented his intake of McDonald's for 30 days, and he ended up having metabolic syndrome. He was obese, he had high blood pressure, he had high cholesterol, he had high everything. And then of course he did a total opposite, and then all the symptoms went away. So just to give you a quick visual, your heart is a beautiful muscle, just like your brain. Like your gut is your second brain. These are some of the suggestions of, ideally, if you had a grocery shop, throw this in your cart. Throw this in your cart. Have this more often than not. I know some of the workplaces you work at may have a Chipotle or a Panera or whatever is convenient. But if you could do the salmon, if you could do, which has great sources of omega-3 fatty acids. If you do a dark green leafy, that's what the spinach is representing. The flaxseed oil, if you wanted to make a healthy balsamic, that would be fine. Your berries, we're not saying fruits don't fit, but we're emphasizing berries for a good reason. The unsalted nuts we spoke about, the avocado that has healthy fats is a great fruit to have. You know, these are some of the items that we want you to consume. Um, so having that understanding, not all foods are organic. So we want to come and educate you on the dangers of genetically modified organisms. We want you to be aware that when you go walking down the aisle with the grocery store, every food that you put in your cart is not going to serve your body in this best way. Genetically modified organisms are foods that come from an organism, such as a plant or an animal, or microorganism that's been a genetic material, or the DNA has been altered in a way that does not occur naturally through mating or recombination, and are referred to as bioengineered foods. If you look in the store, those stores will have a certain label, a label that will let you know that this food has been bioengineered. Some of the foods, the examples I was telling you about, canola, it's a bioengineered food as well. Um, beets, potatoes, cotton, soybeans, corn, papaya, salmon, alfalfa. And I think they're in the lab creating some genetic rice and testing it out on some people in Africa to see if you could live off of this special new man-made rice. But GMOs can cause allergic reactions, increase antibiotic resistance, and introduce harmful genetic changes. It could change genetic material. So we want to be mindful. I know, because we live in Miami and Tri-County area, you know, there's a huge dependence on rice. And I'm really just trying to be proactive and encourage other healthy carbohydrate sources than rice. You know, we're not back in time where you would walk miles and miles and miles and that would be used as fuel. We're not that physically active anymore. So we don't need to eat 3 or 4 cups of rice. It's processed, you know, it's not really good for us, for us. So I don't have nothing against rice, but there are other strains, there are other variations besides white rice. There's wild rice, there's other forms of carbs as a fuel source. So just be mindful. It wouldn't surprise me if rice makes this list in the future. Herbicide residues is linked to reproductive, developmental, neurological, metabolic, micro digestive, urinary system damage, endocrine disruption, increased incidence of breast and other cancers, genotoxic effects, and kidney disease. So when we're eating, because we're trusting the food that we're buying in the store is good, we're doing this on a regular basis, we're doing this on a consistent basis, and we're not aware that whatever this genetically altered DNA is in this food is in our bodies. So it's stored somewhere. So you will see the increased incidence of breast cancer. I don't know if you noticed, there's been increased building of breast cancer or cancer centers because there's a need. And where is this coming from? You know, are we working in chemical plants? No, it could be possibly from the foods that we're consuming. So next slide, please. We want to be very educated and mindful of that. So I thought this was kind of elementary to talk about, but then again, I have to talk about it because I noticed they're strategically placed in lower socioeconomic areas. And I know, you know, for example, if I were to go to, you know, to a steakhouse and get a burger, it probably is a better quality beef than say a Rally's or Burger King. We've all grown up on the traditional commercials. We've all grown up on conveniently buying something from the fast food restaurants, but fast food is not traditionally just McDonald's or Burger King. When you get your TV dinners, that's a fast food. They pay the food photographer a lot of money to make the food look pretty on the package, but is really dead food. So these foods are low in antioxidants, fiber, and essential nutrients. And because they don't offer no live nutrients to your body, it depletes your body, puts your body in a form of malnutrition, but also creates more problems for you in the future. Like obesity, like type 2 diabetes mellitus, cardiovascular disease, liver disease, high triglycerides that leads to fatty liver, high cholesterol that can lead to heart attack and stroke, depression, digestive issues. And just keep in mind, we're here not only for treatment, but also for prevention. So if you know you have your habit every time you get paid, you like to go get your double Whopper with, I don't know, fries, you know, it may not affect you in the here and the now, but in the long term, you don't want to create a problem if you don't have to. I would really prefer you to go and get maybe a lean turkey and make your burger at home, as opposed to going in the drive-through and getting certain foods. I'm not going to down these businesses. There are businesses there that make money, but I'm just going to encourage you, if you had a taste for a taco or something like that, maybe you could buy a lean ground chicken and ground turkey items, and you can make it at home and get a healthier option making it at home, as opposed to, you quickly buying it. You're going to get what you pay for. So if I know the cost has gone up, but the quality's still the same. That's the thing. The food prices have gone up for these fast food restaurants. They're faster with the food, but the quality is not improving. Um, and like Dr. Reynolds had mentioned, and Dr. Gavin, with the current status of healthcare, we're in the trenches in healthcare, and we see that, once you've done the damage to your body, you're here in these settings as a patient. We can assist, but we can't undo 10, 20, 30 years of bad habits. So we want you to learn now, and matter of fact, learn now, teach your children, teach your children's children, so we can nip 2 or 3 generations in the bud for not even developing half these diseases. Next slide, please. Next slide, please. Thank you. Dangers of energy drinks. I don't know if you guys saw this guy on YouTube, Kevin Samuels. He would do his podcast about his relationships, whatever, and drink the Red Bull. He would constantly promote this. And there are other variations of energy drinks that I see all the time, with high stress and high demanding jobs, lifestyle, whatever. It seems cool and it seems convenient. But energy drinks can be dangerous, as they can contain high amounts of caffeine and sugar. The health problems include dehydration. I've never really seen someone have an energy drink in one hand and a bottle of water in another. I just never seen it.
Right.
Digestive problems, nausea, vomiting, heart complications, heart palpitations, increased heart rate, high blood pressure, and it can lead to heart disease, anxiety, sleep problems, insomnia, sleep disturbance. We do have the Cuban coffee. The joke is that's why we keep that little small, very 2 or 3 ounce container, but it's packed so much caffeine. But guess what? The energy drinks contain even more caffeine than that. And sometimes it seems harmless. It says vitamin B12 on it. They try to throw in healthy nutrients on the label to make you feel good about it. B vitamins, and they list all the B vitamins. But at the small print, it's this massive amount of caffeine that you're drinking, and you got this instant energy, and then you crash, and then you know what? You have a dependence, and we don't want that cascade. We don't want that cascade. We're trying to prevent and eliminate problems. We're not trying to keep creating more problems. And once again, it may be for you to really look at your life, and you need to just get your 8 hours of sleep. It just may be something as simple as that, as opposed to getting 4 hours of sleep and drinking energy drinks and crashing out at some point in time. We don't want that at all. Next slide, please. Again, metabolic problems can increase the risk of type 2 diabetes, mellitus, and obesity. Yes, I'm still talking about energy drinks. Yes, that small 12-ounce, 16-ounce can, I'm still talking about it.
Dental problems. Talk to them about it.
Yes, dental problems, dental decay, kidney problems can lead to microvascular damage or chronic kidney disease. So just imagine you go to McDonald's every day for I don't know how many years. You drink your Red Bull. Don't you think at some point in time the body's just going to go and protest and say, I can't do it. I just you're not giving me no water. You're not filtering me right. I can't do it. The body will not cooperate. For children, caffeine can harm children developing cardiovascular nervous system. And I've seen in some Spanish cultures they give their kids coffee early on, but we don't recommend that. Mental health effects such as suicidal ideations and depressive symptoms. So yes, that little 12-ounce can of energy drink that we see is there. I don't know what good reason I can suggest a person to get it under what quick emergent situation. It will just be don't try and leave it alone. If you have been doing it, just cease and desist, just stop, because the problems that these energy drinks cause, You don't want those. You don't want those health problems. Like we're like it was mentioned in the prayer. We have one body, and where I work at, I'm also a transplant dietitian, so I see a lot of transplant patients. But let me tell you, once your organs don't work and you get someone else's organ in your body, you're taking about 20, 30 pills a day to prevent rejection. And guess what? You still have to do follow the dietitian's recommendation. You can't come from around it. So you don't want the problems, but don't think you're gonna win because, oh well, I just get a kidney transplant. No, you're gonna be even on more restriction than if you had your own kidney. Next slide, please. In addition to talking about energy drinks, I wanted to give a balance. Um, there was some conversation about alkaline water. What's a good pH? I said anything above an 8.0. Some have. I'm interested in buying an alkaline machine myself. They use certain metals, certain rocks to alkaline the water. But if you don't have that money, just squeeze some lemon in your water. Plant-based milks. I do hibiscus tea every morning, but you could do green dandelion, chamomile, peppermint. So many you could do as a choice of beverage that won't hurt your body. You could do your own juicing. I do it myself. I combine beets with pomegranate. I do all kind of stuff with natural juicing. You can do herbal infusions, burdock, yellow dog, milk thistle. You can do your warm lemon water to get the gas off in the morning. Coconut water, definitely have a good source of electrolytes, sparkling water. These things won't hurt you, not at all. And even if you did want coffee, I'm not saying you shouldn't have it, but I'm just saying, I know because we have such a fast-paced, stressful life, it would just cause us to just have these habits. So if you do like to depend on something, then depend on hibiscus tea. Like depend on something healthy. Like when you go and you're packing your lunch for work, you could have your hibiscus tea before you get in the car. You can have your alkaline water bottle in your lunch bag. You can have your tea, natural organic teas to do maybe at your lunch break. You can have your coconut water. I could just tell you for me, I'm speaking on myself. I do organic cranberry juice, coconut water, hibiscus tea, a lot of natural juicing, and I don't feel bad about it. Not at all. So if I do a soda, it's no crime. But now if you do soda more than these healthy beverages, we have to flip the frequency. That's all I'm saying. Next slide, please. Of course, be cautious of alcohol, whiskey, liquor. Um, you remember the Hawaiian punch? Because I didn't know any better as a kid. I thought it was like, I really thought that juice had all those fruits in it. It was so bright red. And I come to find out it's like a lower version of Kool-Aid. I'm so disappointed. But sodas, we talked about the energy drinks, the sports drinks. When you go into the gym, they have the refrigerator, you worked out, you burn 400 calories, and then you drink it all back. So be mindful. Caffeine may affect body calcium levels. So, again, be mindful of not only food, but the beverages could be just as offensive. So shopping on a budget or a shoestring because food costs has lost its ever-loving mind. I'm still a good proponent of quality meats. There have been some conversation about some stores not really rotating their meats, or it's not as fresh. Don't do farm raised salmon. Don't do that high fat ground beef. Back in the day, you buy the ground beef and then the whole pan is swimming in oil. Don't buy that ground beef. Do ground turkey, ground chicken, lean ground beef. Invest if you're gonna do the protein sources. Invest in high quality meats. Like I said, preset your grocery budget. Make your grocery list before you go to the grocery store, and you may have to negotiate because you did want that bag of Brussels sprouts, but the price was not forgiving. So you know what you should do? Maybe you could do green beans this time. You could do a substitution to stay within your budget. Take your calculator. When I go grocery shopping, it's a project. I'm looking at the price. I'm thinking of the nutritional value. I'm thinking of my budget. I'm thinking of the preparation time. Do I have the time to make this meal? I'm thinking of a lot of things. But take your calculator because we all live on budgets. Eat seasonally. Some of the fruits we have locally, like you get the Haas avocado, those are imported. But some of the avocado trees naturally, especially down south, they're big, they're beautiful, they're natural. Go to farmers market. I'm a proponent of farmers markets for sure. Purchase food that's in season. Purchase good quality meat. I like to get my meat. I'm particular about salmon, so I like to get sockeye or organic. I will invest the extra money into that. I'll do that. So it's something you may like that. You may invest a little bit more for your health's sake. Meal prep. It's a lot of videos on that. You know, cooking in advance and portioning it out. Buying food in bulk. I buy coconut water in bulk. I wish I had a coconut tree. That's just my thing. When I say minimize dining out often, if you can't afford it, make date night at home. Um, Cook at home more often, meaning if you have to go to work and you typically buy food from wherever at work, try cooking your food at home and taking your foods to work, which is a healthier version. You know what you put in your food. Like I said, your favorite, choose your favorite starch, meat, vegetable, and rotate it weekly. So you don't feel like you're eating the same thing. I can tell you, my husband will tell on me. I like Pollo Tropical. It got my kids through, and both my kids are in the Air Force and in different countries. But when they were growing up, my youngest, she had a little small appetite. My other two, they ate a little bit more. But I'm thinking, I have to go to work. I gotta feed these kids healthy. And Pollo just had opened, and they were promoting their chickens didn't have antibiotics, and their grilled chicken was grilled. And I was like, great. And they had the rice, they did the brown rice, the black beans. I was like, great. I'll just add a romaine salad to it or a Caesar salad, and it worked. And it was affordable. So, again, when you're cooking, you don't have to use what we've learned to see now in our childhood. Lori's accent, Morton's. We're going to talk about that. We know better. We know better, and we're going to do better. So I'm going to speak on, because we have an obesity concern in our communities. And I know a lot of attention has been given to this. I'm going to speak on in this slide and then turn it over to Dr. Gavin, because this is his baby. These are the anti-obesity drugs. And you may not know the names of it, but just looking at this slide shows that over time, you do lose weight. If you look at the weight loss, in all fairness, if you exercise, you probably lose more weight on your own than just with these meds. So at that rate, I'm going to turn over to Dr. Gavin.
And I should point out that if you look at that weight loss, the FDA makes you express it in kilograms. To get that in pounds, you have to multiply each of those numbers by 2.2.
2.2, yes.
And that'll give you how many pounds you actually lose.
So it's on you now.
Okay, so let's keep going. Next, and I'm going to try to run through this portion of the presentation as quickly as possible, because so much is now being made of this new class of drugs, the GLP-1 receptor agonists, GLP-1 RA drugs. This is a group of drugs that actually have been approved for diabetes, but they have effects way beyond what they do for diabetes. So what we know is this, that these drugs actually are capable of mimicking. They actually do the same things as the naturally occurring hormones that our bodies produce. We all make GLP-1s in our body. They regulate glucose metabolism. They cause the pancreas to release insulin when glucose shows up, but they also shut down glucagon when glucagon isn't needed. They help control appetite. They help you get a feeling of fullness when you've had enough to eat. All of these are things that the GLP-1 drugs do in our bodies, and the ones that we take by prescription actually mimic those same effects. The drugs that are now available include tirzepatide. Some of these will cause your tongue to twist up in knots. Tirzepatide or Mounjaro, or Zepbound is the other trade name, semaglutide or semaglutide, Wegovy, you've heard all of these on television, dulaglutide or dulaglutide, Trulicity, and they are now generics. All of these have now had a huge impact on what happens with weight loss. So the ones that are the most common are liraglutide, semaglutide, and dulaglutide, okay? That is Ozempic, Wegovy, and Trulicity. They are widely used. They have different dosing schedules, different amounts of per dose, but a lot of flexibility, and that depends on where you start and how you titrate it. But all of them pretty much work through the same mechanisms. Now, when you look at what these drugs are approved for by the FDA, they were all approved as diabetes drugs, okay? They lower blood glucose. But what was found is that they modify your eating behaviors. But more than that, these drugs have the ability to reduce your risk for cardiovascular disease. That's one of the reasons why they have become so popular. They do more than just help with your blood sugar. They actually do more than just help you reduce your weight. They help you reduce your risk of cardiovascular disease. They help you reduce your risk of stroke, and they help you reduce your risk of kidney disease. So there's expanded clinical use of these drugs, and it's growing because now, beyond the effects that I just summarized, these drugs actually help to reduce fatty liver. They actually reduce the risk of developing fibrotic liver disease. And most importantly, especially for people who are in my age bracket, these drugs are now being shown to have beneficial effects in reducing the risk of Parkinson's disease and Alzheimer's. So stay tuned. These GLP-1 receptor agonist drugs are a growing industry for good reason. Okay, we will be talking more about these in the future. So the thing that makes them important for the discussion today on nutrition and weight control is because they help you suppress appetite, okay? They regulate hunger. They help you to actually achieve a level, a feeling of fullness sooner. And when you get that feeling of fullness, you stop eating. The key is on these, when you're taking these drugs, if you try to eat beyond that feeling of fullness, you get sick. You will get nauseated, you will throw up. That's one of the ways that they help you. Most of us, when we're at the Thanksgiving table, we eat and we feel full. We say, you know, I got to have another little piece of that. And you eat anyway. But now, if you're taking these drugs, you cannot do that. Okay? Okay? I'm not going to go to all of these details, but they delay gastric emptying. That is, the food doesn't go through your gut as quickly. That's one of the ways in which you get this feeling of fullness so much sooner. It occurs earlier. And that feeling of fullness lasts longer. And that therefore you don't get hungry as soon after a meal. So that leads to an overall reduction in the amount of calories that you consume. Some people, when they're taking these drugs, they can no longer eat certain foods. For example, meats. They just develop an intolerance for meats, especially fatty cuts of meats. It's a big, big difference in terms of the patterns of how you eat when you take these drugs. Now, there are a lot of, you saw in that first table that Dr. Morrison showed you, there are a lot of weight loss drugs, okay? It turns out that the GLP-1 drugs are by far and away the most superior. They give the best results in terms of the amount of weight that you can lose over a certain period of time. And the durability of that reduction in weight tends to be longer and more sustained compared to some of these other treatments. But there are some caveats that I want to share with you. Okay, so you get sustained weight loss, okay, with these drugs. You get long-term weight control, but once you stop taking these drugs, the weight can and usually does come back. So it's an unanswered question right now as to whether or not when you start taking these kinds of drugs, do you have to take them for life? Okay, that is something that is yet unresolved. Once most people stop them, the weight starts coming back. The precautions, okay, the adverse events, most all of these drugs cause GI side effects, nausea, vomiting. Anybody that prescribes these drugs for you, if they don't discuss that with you, they're doing you a disservice, okay? But these are symptoms that will gradually diminish over time, especially if you start a low dose and then work up to a higher dose slowly. You have to make sure that you start low, go slow. And we have to make sure that we get the appropriate education about the use of these drugs in order to use them safely and to get the optimum benefit from them. There are certain things that we should be aware of. If you have had a history of what's called medullary thyroid carcinoma, or multiple endocrine neoplasia syndrome. This is thyroid tumors. If you have had those kinds of problems, you should not take these drugs, okay? These drugs are not known to cause pancreatitis, but if you have a history of having pancreatitis, these drugs should be used with extreme caution, and people should be educated about what the symptoms of pancreatitis are if they go on these drugs. And you have to really be familiar with the signs and symptoms before moving forward. Okay, the risk benefit. Weight loss is good, okay? You can manage the side effects, okay, with patient education and selecting the right patients for these drugs, because not everybody is a good candidate for these. Some people simply can't tolerate these. And the fact is that these drugs are pricey, okay? If you look at the advertisements that come across online, you'll find that, for example, the new price for Ozempic and these Wegovy pens, $499 a month at any dose. There are generics. Medv, MEDVI, for example, is one of the generic forms of Ozempic. It's the same drug. It's semaglutide. It's $179 per month. Now, that's a big reduction from $499. But the fact of the matter is, it's still $179 a month. So, you know, when you talk about a lot of us, that is not in our ballpark, okay? So we have to really think carefully about whether or not this is a pattern, an approach that we're going to pursue. And then I want you to be aware of the fact that it's very important that if you have conditions, for example, if you have a known cardiovascular problem, these are drugs actually that may be preferred. If you look at the guidelines of treatment of diabetes, for example, from the American Diabetes Association, if you already have an underlying cardiovascular problem, whether it's peripheral artery disease, a coronary artery disease, a history of a heart attack, or some early kidney disease, these drugs actually are preferred. They are now being recommended as some first-line treatments or used in conjunction with drugs like SGLT2 inhibitors, which are kidney-focused disease. And if you have not succeeded in achieving weight loss and improvement of your condition with lifestyle, these are drugs that become more urgent for you, okay? Okay, start low, go slow. That's all I would say. And most of these are weekly drugs. There's still some that are daily, but most of them are weekly drugs, and they're given through injection subcutaneously, and they're very easy to administer. And then the importance of regular follow-up. You have to make sure that you are part of a healthcare team. You have to make sure that you are staying on it, that you're taking it according to the plan, and that the adjustments in your dosing that are necessary. If you become have GI symptoms, if you become intolerant of it, you may have to pause the titration. You stop the dose right where you are, and don't go higher until those symptoms go away. There's a lot of flexibility that you have to exercise to use these drugs most successfully and with maximum benefit. Okay, remember this. These drugs are important, they're novel, they're very effective, they have multiple biological actions, multiple medical benefits. They offer safe weight loss benefits when they're used in the proper patient and they're monitored with consistency. But they're not for everybody. Over 40% of people who start these drugs will be off of them in a year. And a lot of times that's an indication that they were the wrong patient type in the first place, okay? But as powerful as these drugs have proven to be, they still require careful attention to how you eat, okay? You do not get a free pass in terms of healthy nutrition, even when you go on these drugs. In order to have optimum benefits, even on these drugs, you have to make sure that the kinds of things that you're hearing here today about appropriate and healthy eating patterns will be respected. You have to plan, and that's why meal planning, becomes extremely important. And there are many types of meal plans, and I'm going to turn it back over to Dr. Morrison to walk you through the last little bit of what we have to say.
Thank you. So we just wanted to wrap. I just wanted to mention that thank you, Dr. Gavin. Thank you, Dr. Reynolds, for the opportunity. We are here to crush stereotypes, and I wanted to, out of the 14 slides left, I wanted to go to we eat too much salt in our diets. And I want the panel to know that most Americans consume 8 to 12 grams a day, mostly, that's slide 60, mostly from processed foods, canned soups, TV dinners, convenient foods, fast foods. But we have a new culprit introducing called DoorDash, deliverables. That's where we at.
Yep.
You know, you come home, you don't want to go through drive-through. You can get on your phone, and by the time you get in your house, your food is delivered to your porch, and no one's gonna stop you. It's just the benefit of being in the free world. But just be mindful, all of that too plays a role in salt intake. 10% of sodium is a natural sources, so every food has sodium. 75% added when foods are processed. Processed means, you know, pickles, for example. You take the cucumbers. Have you ever seen on YouTube how to make pickles? You put it in vinegar and you dump a ton of salt in it. And people have pickle aversions. They love to eat the bitter, acidic, saltiness of a dehydrated cucumber. 15% added when cooking or at the table. So if you really want to purge your taste buds, just don't use salt for a little bit, and then you'll be able to taste the salt in everything and realize we are warming our taste buds with so much processed salt that it don't matter what pill we take for high blood pressure, it's going to be a challenge. We really got to get that salt intake under control, and we don't have control when we eat foods from other people. We don't know what they're putting in the food. Most of the processed foods are cheaper for restaurants. So if it tastes good, it's probably a cheap product. If it's battered, if it's deep fried, it has a coating on it, it's going to have salt to preserve the processed item. Table salt is 40% sodium. The limit is 2,400, but if you have high blood pressure, it's 1,500 milligrams a day. That will eliminate everything you've known to eat, only just fresh foods. So, you know, we definitely want to be mindful. Next slide, please. To do not use salt during cooking. You know, putting salt on your food. Some people are heavy-handed. Sometimes when they take that salt, they're so heavy-handed, they don't know how many milligrams they're throwing on their food. I mean, again, if you look at we're in that age of information, they show you how to make potato chips. They show you how corn chips are made, and hot dogs, and salted pork, and salted ham hocks for the greens. And oh yeah. Next slide, please. We really have to be mindful of the amount of salt we're taking in. So the healthier options of table salt would be Himalayan salt that has trace minerals such as potassium, magnesium, and calcium. Whereas regular salt only has sodium chloride. Celtic salt again has electrolytes, calcium, magnesium, potassium, which are often removed from table salt. So if you have high blood pressure, again, you're not going to season your food to taste. You're not going to season your food to taste. But we don't want you thinking I'm on a 0 milligram sodium diet. There's no such thing. But we don't want you feeling, and that's the struggle. I gotta have my food to have taste. My food gotta have taste. It has taste. We just have to detox your taste buds so you can appreciate the natural taste. Next slide, please. So again, eat more fresh fruits and vegetables, minimize your canned and frozen items, eat more natural, healthy veggies, carrot sticks, celery sticks. Those could be alternatives. Look at your food labels. Again, with your TV dinners, the sodium is going to be super high. Don't drink your sodium, your energy drinks, your Gatorade, your sodas. Use your herbs, use your herbs, use your herbs. Cilantro, parsley, onion, thyme, garlic powder, onion powder, lemon, lime, tomatoes. Let that marinate overnight. I know you want to use bouillon. I know you want to use Maggi. I know you want to use all the cultural epis and all that good stuff. You can make a healthier epis, and it's a Haitian type of marinated seasoning for food. We can make a healthier mojo sauce. We want to put our meat to marinate in. But once we start getting that Goya, that adobo, that Lori's, we're not winning. The food's gonna taste good. You're gonna like it, but we're gonna have to keep resetting, keep starting over because the taste buds are gonna be sugar and salted overloaded. And so, how are we gonna be able to purge eating healthy if our taste buds crave salt and sugar? Whew. So yes, seasoning salt, we grew up on it. I saw my mom use it. Lori's, I saw her use it. Soy sauce, we got to put brown in, we got to put a little color on it. Again, those seasonings are loaded with sodium. They don't have the minerals, they don't have the electrolytes. The deli meats, get the boar's head unsalted. We're in such a great space right now where you can get stuff super healthy. And it's not because you want to be bougie, but you do want to treat yourself better as you get older. Your organs are older, you're older. So, keep that in mind. What you could do at 17, you got to be mindful as you get older to treat and handle your body a lot more gentler. Read your labels. Read your labels. Those labels are there to let you know when you see serving size half a cup and you eat the whole thing and it says it's supposed to serve 5 people, those numbers you multiply by 5.
Exactly.
So you have to look at the labels and say, well, I only had low sodium chips, but how bad was the chips? How big was the bag of chips? Well, it was for 3 people. Well, you didn't have low sodium at all. There was nothing low sodium about it. Next slide, please. Again, avocado oil, flaxseed oil, uh, you know, olive oil. Take the skin off the chicken. You can leave some of the fat globules, but take that skin off. Lean sources of animal, egg whites. You could do the egg yolks, but not too many. Fat-free items. You could do sorbet if you're lactose intolerant for ice cream. All the nuts are your friend unsalted. I put still cut oats because the processed oats is no good.
Yep.
I put don't use lard. Some fry with lard. They want that real hometown. I'm pretty sure if I went to Paula Dean's restaurant or Palaville's restaurant, she's gonna go all out with the right type of cooking supply to make that chicken pop. But in this case, palm oil, is in a lot of processed foods, or when you dine out, I should say. That's the oil that is in a big container and the chef's using it, throw it on the grill, and you will never see it. I see it though. So the palm oil, we eat it when we dine out. And I don't know if it's inappropriate to say, "Hey, can you use olive oil?" I'm not sure the restaurant will have that available. Put extra garlic on my salmon, but that's home use. If you do that often, then you can afford to have a burger, out on the town. But be mindful, the restaurants are not there to cater to your healthy needs. Depends on where you go. If it's a higher end, maybe, but the responsibility is always going to be up to you. So you can have a wheat bagel, 1 ounce, not the big oversized bagel with all that flour. No, but you can have a wheat bagel, 1 ounce, and you can have low fat cream cheese. Sure, no problem. But then again, if you have a 16-ounce cup of coffee with 12 packs of sugar, what's the point? See, these are some apps that you can use and consider. Some are kid-friendly recipes. Again, you'll get a copy of this. And we want to give you as many resources as possible. And these are references, so we did not make none of this up on top of our head. But this concludes my presentation. And I think, again, those who've attended, please come back again. This is a great start. And any questions?
Let me address one of the questions that popped up in the chat box, and it had to do with people who are vegetarians, especially getting proteins. And the person says, "I'm not on any medications." And I would ask Dr. Morrison to address that. But of course, with vegetarians, you want to make sure that you maintain good sources of proteins. That's why we talk about beans and legumes and nuts and grains and things of that nature. But that may also extend depending on whether or not a person how strict the vegetarian you are. You may even have egg whites allowable. So Dr. Morrison, you might want to speak to that to a person who is concerned about that.
So with the strict vegans are the ones that just do plant-based. They're the ones that do fruits and veggies raw only. And then you have your semi-vegetarians that will consider other items included, a pescatarian, which will do fish and fish sources. Lacto-ovo will do egg and also dairy sources. And then you have the vegetarian that really is not so strict. Meaning, if you had an item that was mostly with no meat, they won't really go into the ingredients and see it says, oh, it's made with casein, so I can't have it. It's derivatives of milk product. But to get sources of protein, you do have to consider plant-based source proteins, which are in the vegetables, which are in the beans, which are in the nuts, which are in the seeds, which are in the legumes. And 1 gram per kilogram of body weight will be sufficient amount of protein that you need daily. Not for wound healing or extra nutritional needs, but if you're 60 kilos, then you need 60 grams of protein a day. And you would look at the bag of beans and it'll tell you 1/4 of beans will give you 15 grams of protein. So that means for the day, you probably would need 1/4 times 4, probably up to a cup and a half of that type of source of protein. Some people use the powders, the protein powders, but again, some of them are made with whey, some of them are made with casein. They have other they have derivatives of milk, I should say, as forms of protein. So you have to look at that as well when seeking the adequate amount of consistent intake for your day.
And there's somebody that wants to know about, are there any risks associated with the long-term use of weight loss medications? Before you go on any weight loss medication, make sure that you are completely familiar with, one, what the benefits are and what the risks are. So that means you have a shared decision-making process with the person who's prescribing it, but you also read the label. What we try to do with you is provide you with information that helps improve your awareness about your own health, but also that stimulates your curiosity about what's happening to your body. Don't take anything that you don't feel that you have a comfortable understanding of. And if I prescribe it for you, I owe you some information about that, but I also owe you some tools about how you can find out more. Okay, so that's why we try to give you references. We try to give you sources that you can go to. For example, the GLP-1 receptor agonists, the GLP-1s, like the Mounjaro that you heard about. Well, you'll hear it said that they cause pancreatitis. No, the evidence is weak that they cause pancreatitis. But people who've had pancreatitis, they may be at risk for developing it again. That's why they have to be aware of what the signs and symptoms are so that they'll know early whether or not this is a problem. But the older weight loss drugs can be associated with a number of things like behavioral changes. But you need to know those things. And you can find them out from discussions with the provider, as well as check with Dr. Google. There are a number of ways of getting those kinds of insights about long-term effects, and it's important to know.
So a question was asked about protein bars. The most purest form of protein in plant-based concerns would be what I mentioned before: seeds, nuts, lentils, that type of thing. And then if you're a person that eats meat, your lean fish, your lean chicken, eggs, lean beef, those are protein sources. And then your protein bars are just a more processed version, with the whey protein, the casein protein, if you don't want to be bothered with plant or animal protein sources. But, you cannot meet your nutritional needs with protein bars. Like you can't, you probably get tired too of trying to eat your way to your protein needs with protein bars. Protein bars usually are after you work out, something like that, a quick fuel type of thing. So that's not the best source for protein intake. It's just a quick get your 20 grams in after a workout, something like that.
One of the things that we probably should say is that moderation is a very important theme, okay? Because a lot of things that we hear about, somebody asked about sweeteners, the different types of sweeteners that people use in their coffee. Sometimes they use sweeteners in their drinks. You'll read a lot of information about risks associated with these sweeteners. Well, many of these risks are going to be associated with what we would consider excessive use. Okay, if you're using 1 or 2 packs of these sweeteners a day, the likelihood is rare if you're going to be having a problem with that. It's the excessive use of these kinds of things. For example, the what you heard about these energy drinks. Yeah, there are people who and caffeine containing drinks. There are people who drink these things instead of water. Okay,
Right.
this is when you get into problems. So moderation is extremely important. We have 2 things that we emphasize as themes for lifestyle, and one of those is the theme of less than you're doing now, and the other theme is more than you're doing now. Less than you're doing now means fewer calories than you're consuming now if you have a problem of any sort with overweight or obesity. Fewer, less intake of things like those sweeteners that we were just talking about, less intake of things like the caffeine that we've been talking about. The other side of it, more than you're doing now when it comes to physical activity. If you're only getting 500 steps a day, you need to get 5,000. Okay, so those 2 themes we want to keep in front of you. Less than you're doing now if you're not at goal in terms of where you ought to be with control of your weight or control of certain of the chronic diseases. You need to be doing less. More than you're doing now when it comes to the physical activity. Listen, we're not going to change anything overnight. You got to start low, go slow, but move in the direction of healthier change. Those are the kinds of themes that you're going to be hearing from us over and over again. Much of what you've heard today, you will hear portions of this again in subsequent topics that we talk about. Because remember, these things that we talked about today have a lot of relationship to many of the chronic diseases that we will be talking about, the heart attacks, the strokes, the kidney disease. All of those things we'll be talking again about elements of nutrition and lifestyle when those topics are presented to you.
Can I ask a question?
Please.
I work out almost every day. So I would like to know about what you feel about protein shakes and also electrolytes before or after.
Demetrius, you want to?
Yeah, I think with you having a consistent exercise regimen, that's great. Again, with regards to protein, 1 gram per kilogram of body weight. So if you're 70 kilos, you should consume about 70 grams of protein. And then when you're looking at protein shakes, they kind of tell you, 1 scoop is 55 grams of protein. And I've had to, because I also see bariatric weight loss patients who have weight loss surgery, they cannot do carbs at all. So they depend on 0 carbs, high protein shakes. So we do counsel them on how to get adequate protein so you keep your hair, you keep your nails, you keep your skin tight. So minimum 1 gram per kilogram of body weight for your protein needs. And then as well as your hydration, the misnomer that you need 8 cups of water a day, that's true. But again, for 1 ml per kilogram of body weight for fluid intake.
And I think it's important to reemphasize, we need to become more sensitive. All of us need to become more sensitive to how much am I taking in? What am I getting when I eat this or when I drink this? Most of us just drink what we drink, eat what we eat. Well, we're trying to make sure that we start becoming a little bit more quantitative about this because amounts are important. Composition, what's in it? Those things are important. And the more we learn, the more sensitive we are to that, the more we're going to be curious. And we'll start looking into those things to see whether or not we're on target or we're off target. We doing ourselves harm or we doing ourselves benefit? Those are the kinds of things that we want to try to help with. And hopefully these kinds of insights will be useful to you.
Dr. Gavin, there was a question that actually came in prior to the Zoom recording today, and that stated, how do I reverse prediabetes and cure neuropathy? Does berberine help with these medical issues?
So let me address the issue of prediabetes because, and I can do this in a very personal way because I have prediabetes. I've had prediabetes for 13 years. Okay, but my prediabetes has not progressed to diabetes. And what you would say, well, it shouldn't. You're an endocrinologist. You ought to know what to do. Well, I do know what to do, and I really worked hard at doing that. Okay, so prediabetes. Remember, you were given the guidelines. If your A1C is between 5.7 and 6.4%, that's prediabetes. You don't want that to go higher because you don't want to spill over into diabetes. What are the main things that can prevent prediabetes from progressing or cause prediabetes to go back to normal glycemia, which is what we all want to be? Weight control, okay, and improving your physical activity. There was a major study called the Diabetes Prevention Program, which I participated in the 1990s, which showed that lifestyle changes, the introduction of regular physical activity, and the achievement of as little as 5% of your body weight loss. Okay, if you start out weighing 200 pounds, if you lose 10 pounds, okay, over a period of time, that was enough to cause your prediabetes to revert to non-prediabetes or not to progress at all. The other way of preventing prediabetes from moving forward, a simple drug like metformin, okay, once at night, okay. The most powerful intervention for prediabetes, lifestyle. Metformin has also been useful. A variety of drugs have been used, but nothing is approved by the FDA for prediabetes, okay. But the most important intervention is lifestyle change. And I'm a living witness for you, okay? 13 years I've had it, and now I'm still, quote, carry the diagnosis, but my blood sugars are flat out normal. So that's my testimony in addition to my answer to your question.
I just wanted to piggyback on lifestyle changes. And we do have our preferences. Perhaps, we like to go to Dunkin' Donuts to get our coffee and our bagel. Again, what you eat does matter. If your pancreas is very sensitive, because when we do diet education for metformin, you do have to have some parameters of taking a medication, I think half an hour before you eat. So when we do the education, we tell the patients, now we're going to teach you on carbohydrate counting. We're going to teach you on portion control. Now, I know you're going to be a little mad, but you're going to get maybe some Ezekiel bread, or you're going to get a whole grain bread that's a minimum of 5 grams of fiber. You got to get your fiber intake at least 30 grams a day. And if you're eating white products, white bread, white flour, white sugar, white rice, white salt, you're not going to get no fiber at all. So you just may want to do a salmon salad, and you just may want to complement that
came in. Oh, go ahead, doctor.
With whole grain bread, and that will get you at least 15, so you're halfway there. So you know what comes in comes out. The fiber helps you have a good bowel movement. The fiber helps you bind cholesterol and excrete through the bowel movement. So we want you at least at 30 grams of fiber daily. That's all I want to say.
Thank you, doctor. Another question that came in: every time I eat sugar, anything with sugar in it, my feet start hurting and I feel numb. I feel really sick. I'm tired and I get migraine headaches.
Well, that's a tough one. Without knowing how much sugar you're eating, what form are you eating it in, it becomes difficult to know what that might be due to. Remember, neuropathy can be one of the early complications of diabetes, and that can be in the form of tingling, numbness, even pain. But you don't generally develop that until there is a disease present. In other words, neuropathy doesn't just happen idiopathically for most people. It happens in conjunction with some other underlying disease. So if you have a neuropathic process going on, you have to first find out what else is happening with you. So this is a case where I would need to know, one, do you have diabetes already? Two, what form are you eating whatever this is that's causing you to develop these symptoms? How much of it are you eating? And what else is it associated with? Is it in a drink? And it may be something else in that drink that's partnering with the sugar to cause you to have symptoms. So this is something that requires a little bit of an investigation with you as the subject in a more comprehensive way.
Thank you, Doctor. Another question that had come in was, does aging increase your risk of developing high blood pressure?
Well, all of the chronic diseases that are what we call cardiometabolic diseases, okay? Cardiometabolic diseases are the ones that we group with diabetes, blood pressure, kidney disease. All of those have an increased potential as you age, okay? Because one of the things that they're associated with is a process called insulin resistance. And insulin resistance as an underlying process is something that actually can increase as you get older, okay? But now it's not automatic that just because you age, it's going to happen. Because remember, other things happen as you get older too. One, you become less active, so your physical activity goes down. Two, you start gaining weight. Okay, so your baseline body weight can go up. So you have to factor all of those things in and not just look at what has happened to the calendar. But in general, cardiometabolic diseases that include hypertension and diabetes do happen more often as a function of getting older. But don't just blame aging. Look at those other things as well. You have a chronological age and you have a physiological age, okay? Chronologically, I'm none of your business, but I'm that age, okay? But physiologically, I'm told all the time, even by people like Dr. Dwight Reynolds, that, you know what, I act and look really young. Well, he might be fibbing a little bit, but the fact is, physiologically, I'm much younger than I am chronologically, but that's because of lifestyle and other things.
I'm gonna tell you age.
No, you don't have to. That's your business.
Thank you, Dr. Gavin. And I have one more question I'm going to present to you all, which I think a lot of people are curious, concerned about with the state that we're in right now in our nation. What cuts to Medicare are in the works, potentially, if you know? And where is it at? I'm sorry, you guys. It was, what cuts to Medicare are in the works, and how would these changes affect the physicians we now have?
Well, Dr. Reynolds is chomping at the bit to
I can answer that for sure. Right now, what we do know is that $850 billion, that's only a few billions from being a trillion, has been cut from health services in general. Right now, the sacred cow so far seems to be Medicare, but that's something that they may increase the age from 65 maybe to 67, 68, all right? The other thing is the big cut out of Medicaid, not Medicare, but Medicaid, is very significant in that it typically involves people that are over 65 years old. People don't seem to understand it, but Medicaid, more dollars go to seniors, amen, for Medicaid than to young folk. That's just bottom line. It covers things like nursing home care, aftercare, certain food products that they may need to have, transportation, Meals on Wheels, all of those things are associated with Medicaid and not Medicare. I can tell you that in talking with the people on the ground, talking to people up in Tallahassee and as well as DC, that the environment that we're in right now is uncertain. It's like the economic picture is uncertain. Well, guess what? So is the healthcare system is uncertain. We do know that vaccines, I have to get on that because, remember, I was one of the guys that was doing a lot of vaccines here in the state of Florida, as well as other countries. Our team did. And they're trying to, as of this past week, totally take away the mandate of vaccines, all vaccines in the state of Florida. Okay. Other states have begun to look at it as well, like Texas, Missouri, and some other red states. We call them red states, right? I'm a physician, by the way, for everybody. When I took my Hippocratic oath, and so did Dr. Gavin and others. I'm sure that Dr. Morrison may have done something very similar to that. We take the oath to take care of everybody. Our thing is to relieve pain and suffering. And the most important part of what we do in terms of our oath, above all else, do no further harm, right? We know for a fact that polio was eradicated until someone started tinkering with people not having to take the polio vaccine. Measles, pretty much off of the radar screen. When I worked in the emergency department, I'm a ER doc. That was unheard of to see it. But nowadays, guess what, guys? It's coming back. Our good friend COVID. I'm sure y'all remember the big Delta strand where we were using monoclonal antibodies such as Regenco. They're taking it off the market, period. COVID vaccine itself is an issue. CHP, we're trying to alleviate some of that anxiety. We know that if you're over 65 years old, you definitely can get your regular COVID vaccine. If you're under 65 years old, you have to have a pre-existing condition. Well, guess what we do here at CHP? Our grant deals with nothing but chronic disease. So I can qualify everybody that we see as a pre-existing condition. You have to get a prescription, but guess what? Dr. Reynolds happened to be one of about 5 or 6 physicians in the entire state of Florida that is known as a physician. We call it a dispensing physician. So if you come here, there'll be no big cost to come here. You can get your vaccines here. I'll write your script. We go into our freezers, get it out, and we can give that to you also. So although we are facing some very difficult times, the one thing I like about us Black folks especially, we know how to deal with that. Our forefathers dealt with that. They call slavery. I could not have been a slave. I'd be a ghost, a 200-year-old ghost probably by now. But the bottom line of it is that we are resilient people. We always respond. And that's why when I sent out several times, if you guys, I'm sure you guys must have gotten it, emails directly from me about how important this moment is. This is our moment to do our job as physicians, healthcare providers, and I'm just so happy and thrilled that we have such a unique team. I'm sure that, like Dr. Gavin, I'm sure that Dr. Morrison could have been anywhere now. Her education is second to none. She's one of the very few African Americans in the country, amen, in the country now, that has not only the degrees, but she has that ability to communicate with us. And never forget this, guys. There's been all kinds of studies out there regarding the outcome, the clinical outcome of Black patients, especially. Harvard has done the study, Yale, Princeton, the HBCUs have done the study, the AMA have done the studies, come from everywhere. And guess what the final conclusion is? Black people have better outcomes when they're treated with physicians that look just like them. That's just the bottom line. You can Google that. It's the bottom line. That doesn't mean that we're all good, but I got some brothers and sisters out there now, doctors, that are not good. But I tell everyone, our team, that includes Dr. Gavin, that's now going to include Dr. Morrison, that includes Dr. Cardiologist, Dr. Lewis, and others. We're here as your advocate. So in this tough time, most people know my number. If not, you guys need to get that. And people know they've called me at all kinds of strange times of the night. I don't mind that. I'm one of those old-fashioned docs, but I'm your advocate. We're your advocates. So if you feel that something is not right, let us know. If you cannot find care, let us know. Because there's a such thing called a federally funded, which is a community health clinic. These people have to take you whether they want it or not, whether they want to or not, rather. And our job at CHP is to make sure that we guide you through that particular maze, to make sure that you've been seen, properly seen, you've been screened, had your diagnostic studies, and that you're on your proper medication if need be. When we do these community health events, that's the other thing, guys. Community health fairs, we're able to treat you there, blood pressure issues, I put you on medications. We have other doctors and nurses here too. Take your blood pressure. We do A1Cs. We do a lot of different things, guys. So the services are there. You just need to utilize it. So I don't want to say, woe is me. Yeah, we had some tough times. But for us people of color, when it's tough, we get a little tougher. I'll leave it at that.
Can I ask a question, please?
Yeah, go ahead.
My grandmother is 102 years old.
Bless her heart.
Yes, she has high blood pressure. But her doctor has told us that there are not enough studies for people her age to basically determine an elevated blood pressure, that we would not look for her blood pressure to be 120 over 80 or whatever. So what are your thoughts on that? What should we look for?
I have a good thought on it. Remember, I'm a doc, so I have a little knowledge about a lot of things. This is the deal. I tell people all the time, your normal blood pressure is said to be between 120 over 80. That may be normal for you, but it may be abnormal for me. Give you an example. If I have a patient that comes to the emergency department, they have a blood pressure of 100 over 60, totally asymptomatic, they're doing fine, no problems at all. They're not dizzy, not lightheaded, no chest discomfort, no shortness of breath. Then that, guess what? That is their normal blood pressure. So if they see me with a blood pressure 120 over 80, the pressure just went up. There's no such thing as, my grandmother, by the way, she would be 110, Mother Reynolds from Woodville, Mississippi, by the way. Okay?
Wow.
110. She taught Sunday school until she was 107, by the way.
Wow.
She died peacefully in her sleep at a good old age of 110. Okay? Do you not know that my grandmother was on medications too for blood pressure issues? Okay, she had one of the longest procedures done at Tulane University over there in New Orleans. You know what that was, Dr. Gavin? She had hyperparathyroidism. They had her neck open for about 7.5 hours to pick out those little tiny parathyroid glands. At that time, she was 97, did extremely well. So when I hear people tell me about the aged, those people that, well, we don't know about the studies, forget the studies. Treat grandma if she needs to be treated. But I tell Black people this, the #1 medications that we start on Black folk, if they haven't tried it yet, it should be either amlodipine, which is a calcium channel blocker, amlodipine. It's being recorded so you guys can get it later, amlodipine. The other medication is a thiazide type diuretic. I heard Dr. Morrison talk about eating salt and talk about pickles. I'm sorry, Dr. Morrison, but I eat my dill pickle, at least 1 or 2 every evening before I go to sleep. Not only eat the dill pickle, darling, I get the zesty dills, the elastic zesty dills, right? The big one, the slices, right?
That's what we call too much information.
Now, listen, leave me alone.
Thank you. Thank you.
People still here. I actually put salt and pepper on that, take a little bit of Tabasco sauce, and I have a wonderful time. And guess what? I'm peeing almost all night because that diuretic is still doing its job. Amen. My blood pressure, by the way, Chris will tell you, my wife will tell you, runs anywhere between 110 over 60 over 70. I'm 74 years old. I get my age up. Amen.
Dr. Reynolds, can I ask a question?
Yes, ma'am.
In the last, to piggyback on what the other, the woman asked a question regarding hypertension in the elderly, how does systolic hypertension change, or does it change how we assess and how rigorously we're going to treat hypertension in the elderly? And I'm reading and I'm remembering the work of Dr. Elijah Saunders, who was one of my mentors at University of Maryland.
Yeah, appreciate the question.
Yes.
This is I call it my simple answer to that. The heart is a muscle. It's called a cardiac muscle. Unlike skeletal muscle, which is your legs, your thighs, all other muscles, right? When you exercise those muscles, they get bigger, but the blood supply to it increases also. I don't care what age you're at, You can be 10 years old, you can be 100 years old. If your heart has to pump against pressure that's upstream, we call it your diastolic pressure, that's your resistance pressure. That's a pump against that over a period of time, the heart muscle gets bigger, but guess what? The blood supply to it does not, right? So that means that grandma, who's maybe 100 years old, she needs to be properly treated. Blood pressure got to be brought under control. Because every time that heart beats, we call that a stroke, right? Stroke volume. Every time the heart beats, it's beating against a higher pressure. When it does that again, the heart has a tendency to grow bigger. It gets to, there's a thing called, I'm not going to say it, but it's a Starling heart law, and I'm sure that all the doctors know that stuff. But what happens, you get to a point where there's no longer any compensation. That's when you begin to fail. That's called heart failure, congestive heart failure, right? So what you want to do is if mother's echocardiogram, which I'm sure she must have had that, because an electrocardiogram, an ECG, they call it EKG, but the ECG is giving you about the electricity of the heart and how the rhythm of the heart is, right? Atrial fib, atrial flutter, da, da, da. But to me, what's very important and critical is I want to know about the structure of the heart. How big are those chambers? How thick are the walls? And how much, with each stroke that the heart takes, each beat that the heart makes, how much of that blood is coming out of the chamber? That's what we call ejection fraction. So with your grandmother, whomever it is, I want to know, I'd ask the doctor, I'd probably trip him up a little bit. Doc, can you tell me, what is Granny's ejection fraction? You're going to take note of that. It means you've done your homework. Because again, every time the heart beats, if the pressure is high, over time, it's going to get bigger. And that becomes a problem. I love these questions. Bring it on. Talk to me.
Can I just add one quick thing? And
Sure.
that has to do with the changes in things like blood pressure in the elderly. An important consideration is to make sure that you compare where they are now to where they have been traditionally over the prior decades. Okay, because that matters. If you have somebody whose blood pressure, I'm thinking about my mother-in-law who died at age 98. At the time she died, her blood pressure was 110 over 76. Okay, now that had been, her blood pressure had been in that range for most of her adult life. In the entirety of her 70s, her systolic blood pressure, just like my wife's, would always be in the mid to high 90s. Okay, so by the time she died, it was up to 110. So that meant that over those next 2 decades, it changed by about 10 millimeters of mercury. So those are good benchmarks to know. If you have somebody who's been running along at a systolic blood pressure through their 70s and 80s, if they're blessed to live that long, at 110, 120, and now they're 160, that's a big change, okay? But if they are now, 130, it's probably not, a friend of mine used to say, 10 millimeters of mercury per decade over the age of 80 is not a huge change when you consider the aging process and what happens to us as we go through it. So there are some benchmarks that can be useful so that you don't get alarmed too much by the numbers that you see. I could give you the same arguments about what happens to glucose. I won't right now in the interest of time, but it also creeps up as a function of increasing age.
I'm going to leave you guys with this, because I always like to talk about this when we start talking about the heart. God made the heart such a wonderful and well thought out organ. It's incredible to me. To me, I think it's the center of our universe, not the brain, because without the heart pumping, brain gonna die too. So someone said someone 100, let's say 100 years old. I want you guys just write this down, and it's gonna be recorded anyways. But check this out, guys. I'm gonna put an average beat of 75 beats a minute. Okay, there's 60 minutes in an hour. So I'm multiply the times, that's 75 times 60. There's 24 hours in a day. There's 365 days in a year. Do you know how many heartbeats that is? That's 3,900,000,000 142 million beats in the first year. You take that woman that is 100 years old, hey man, you multiply that bad boy out, that's 398 billion times plus heart is beat. And we know that's beat because she's still alive. When the heart stops beating, you're dead. So just do that. You guys need to do that with yourselves, with your family members, let them know how important the heart is, because it tells us how important it is to maintain good heart health care for your heart, your blood pressure, the salt that Dr. Morrison and Dr. Gavin always hit me on, okay? I know those things, right? But I just want you guys to understand just the power of the heart itself. It's never stopped beating unless you're in cardiac arrest. That means that you're pretty much dead. If the good Lord willing, you may come on back if that's the will. But the bottom line of it is, again, 75 beats now. The average beat is probably right around 80 or so. So I just take it down to 75 beats a minute, times 60 minutes, times 24 hours in a day, times 365 days in a year. That's what your beat is for the year. Then you multiply that times the number of year old you are. It's going to freak you out. My heart is beat a little bit over 76 billion times without fail. I may have maybe a little extra heartbeat here and there and stuff, but the bottom line is this, is that the heart is where the action is. And that's why with our next webinar, it's like about 45 people have already signed up for it. I'm happy to see that, because that we'll go over that too, but it's about those warning signs. Heed to those warning signs. You want to try to prevent having those warning signs, and the part of our webinar, we'll talk about that. So when you guys get me started, I know Dr. Gavin is like, oh Lord, got right started. I'll stop, but if there's another question.
Dr. Reynolds, yes.
Yes, sir.
My blood pressure tend to roller coaster from maybe 120 something, but it averages within about almost 130. It will go up to 160. That's on the systolic side, but my diastolic ranges from 50 to 60 some on average. So it is lower, and my heart rate is ranges around 50. So beats.
Okay, so are you on a calcium channel blocker, a beta blocker?
Yeah, I take a couple of medicine. Yes,
but I get that, right? This is a deal behind what you're gonna want to know. Basically, your heart will be in great shape. The big thing, remember I said before, heart beats against what? The resistance downfield. That's based by the little fine little tuners that we call arterioles. That is what sets your diastolic blood pressure. So when your heart is pumping the blood out of the left ventricle into the aortic arch, into your systemic circulation, that's where the issues are. You are very highly unlikely to have a congestive heart failure issue, period. Doesn't happen that way. Your heart's not gonna get big. Your top pressure, your systolic pressure, we're concerned about that a little bit, but the most important pressure is your bottom pressure.
Okay.
Now, if Dr. Gavin wants to say something about that, he can feel free to do that, but you know, I'm the man when it comes down to this stuff, but go ahead. Dr. Gavin, you can go ahead and say something.
No, I think that's exactly right. I mean, when you told me that your diastolic pressure is 50 to 60, remember that that's your resting pressure. That's when your heart, your system is relaxing. Okay, that's when your heart is filling up, and when you're in a 50 to 60, if you're able to sustain a diastolic that's less than 80. You're actually in pretty good shape. And if your average systolic blood pressure is you said it may roller coaster, it may go from 130 to 160. It means your average may be 140. Okay.
Yeah.
So if your average is 140, you're not going to be generating a pulse pressure, which is the difference between your diastolic and your systolic, your baseline and your peak. You're not going to be generating a pulse pressure that's going to get you into trouble. So your vascular system is likely to stay in pretty robust shape under those circumstances.
Yeah, and let me tell you something also about that systolic pressure. Systolic pressure is typically a response to something happening around you. Environmental stresses, maybe. People come to the emergency department and they see me or some other doctor, whatever it is. They get that white coat jacket type of syndrome. Systolic pressure goes up. But very rarely does the diastolic pressure move at all. So usually you can just calm yourself down. Get into a little zen. Calm yourself down a little bit and that pressure will come down.
And stay away from pickles and putting Tabasco on them and stuff like that. Don't do stuff like that.
Don't get.
Come
Next
to one
question.
of our other webinars when we have, Dr. Lewis on, who's
Oh,
a
Lord,
cardiologist, and he will
that's coming
also
up.
weigh in and
That's
provide you with some
27.
input on this, okay?
Thank you.
Thank you. Thank you.
I do you have any other questions? As you see, we can go here all day because we love talking to us. We know this is not some unusual times. People will have to have more time to ask questions. We need to make sure we get the information out there, so it takes up more time to do that.
Can I make one closing comment?
Yeah, please.
Emphasize something that you said earlier, because I really do want to make sure in this season, when we're seeing reductions in health services and cuts in very sensitive categories of healthcare in our communities, Dr. Reynolds mentioned this, but we really do need to hear from you. If you find that there are services that were available to you, that you did have access to, that are no longer available, then we need to know about that.
That's no.
Okay, so make sure that if you have that experience, please share it with us, because that's going to be part of our advocacy effort.
Yep.
We won't know how much and what areas we need to be more urgently advocating in if we don't know what the situation is in the various communities. So please make sure you provide us with that information in the event that it happens.
I always say, help us, help you. Okay, let's do it. Next question. Someone had a question.
Yes, it says, when should you seek medical help for elevated BP, hypertensive crisis?
Oh,
Well, if you come to me for hypertensive crisis, you're in trouble,
oh,
bro.
good God.
You're in some deep trouble.
You've waited too long.
You waited too long. I mean, then I'm gonna look at, start some IVs on you. We're gonna do EKG. We're gonna test the basic stuff, but more importantly, we're gonna get some labetalol in your body IV wise. Maybe some nitrite to bring it down fairly quickly. It kind of depends. But what you want to do, you want to avoid that. So the reason why, by the way, most Black men stop taking their medication, amen, because they cannot make mama happy at home in bed. They call it ED, okay? And I've seen men come in stroked out, heart attacks, because they were on Viagra, Cialis, or Levitra, something like that. And all of a sudden now, they don't want to even tell the ER doc what they did. Well, if they do that and they come with a heart attack, we know they have a heart attack, cath lab had already been notified. The EMS system send us in your EKG. We know that you had what we call a STEMI, an ST elevation, myocardial infarction, heart attack. Now you need to go up to the lab, right? But before that, you come through the door. First thing that we ask you is, have you been taking any of the ED medications? If you say no, and we give you nitroglycerin, we're thumping on your chest. You're dead. You follow me? So it's really important, guys, to make sure that you take your medication. If you take your medications, and you may have some issues with them, right? But talk to your doc or talk to us. Call me up. You can call anytime. I'm your advocate.
And I'll say this, and then I'm done. But that's why it's important to have regular follow-up. That's why it's important to come to things like our health fairs, because these are silent killers. Remember, you can have hypertension, you can have high blood sugar, and not know it for years until somebody's checking you out. So make sure that you have some kind of contact with the healthcare system so that you can get early detection if there's anything going wrong or developing in a direction that is not good for you. So very important.
All right, guys, take care. Be blessed.